I want to say that I'm very honored to be able to present this webinar under the Sakura webinar series. And I want to commend all of you who are in the listening audience for your commitment to continued growth and development. When we talk about something as routine as the H&E stain, oftentimes this can get overlooked because we do this every day. We don't really give that much thought to it. But I think once we go into this presentation today, you'll see that it actually is not a routine stain. It is a very specialized stain, specific for special entities within the tissue. So for you all to want to continue your growth and development on something as what's considered routine as this, I commend you. Even for those of you who have been in the field for a number of years, I think it's a good refresher for us because we have a whole new generation of younger technologists that are coming into the field now, and many of them have not gone to schools. They've been taught on-the-job training, and some of the things that we're going to discuss here today about something as routine as H&E needs to be emphasized to them so they don't just consider it to be a dye. So what we're going to be talking about today is a systems approach to H&E staining, not just routine H&E staining. We will be covering a lot of troubleshooting, a lot of procedural methods, but the key thing that I want to focus on today is a staining system rather than just some arbitrary hematoxylin dye from one vendor and eosin dye from a different vendor. There are new products that are on the market now from a couple of different companies that are to be used as a complete system. And what these things do is they have buffered reagents and the pH is maintained so that your staining run will give you the consistency from first slide to the last. Oftentimes we don't look at the last slides. We review our first slide to make sure from a QA standpoint that everything is staining the way it should. But by the time you get up to 500 slides or certainly 1,000 slides, if we take a close critical look at that, you can see that some of the stain intensity has diminished. And that's because just running that many slides through, the chemistries of those dyes and reagents has somewhat changed. Well, a staining system is designed to minimize, if not eliminate, those changes because the reagents being buffered and the dyes being buffered will not allow the pH to adjust itself or to change itself. So, and what we're talking about is being able to maintain the same intensity that you started with during your run. You optimize your run based on the preference of your pathologist, whether he likes it darker or lighter, but you want to maintain that consistency in staining throughout your run. So what we're talking about is hematoxylin and eosin staining. And what I've done is I've put this up on the screen, and you should see an image right now of early cartilage cells. These are chondrocytes that are picking up with a deep staining, nuclear staining of the hematoxylin. And because they're early cartilage cells, they're very rich in DNA material, and that's why they're picking up so much hematoxylin staining. And then also you see a slight contrast around that with the contrasting stain to the cytoplasm and connective tissue. The light blush stroma, tissue stroma that is bordering those chondrocytic cells, or that early chondrocytic strip. What you can also see is red blood cells staining. These are very, very bright red, if you can see. I don't know how it appears in your resolution, but the question was, did we use floxine? And this is the point that I want to make going into this. Normally, to get red blood cells or tissue elements this red, you would need to use floxine, but by the way that you can manipulate your H&E stain, you can actually get rich staining as if you were using floxine just by using something like your regular alcoholic eosin. So we want to talk about that today too, a little bit later. But what I like to do when I do this presentation is I just put up a slide of smooth muscle cells. And what I ask everyone to do in the audience, grading this H&E stain from 0 to 10, 10 being the highest or 10 being the best, how would you rate this stain? And it's an arbitrary question. There is no right or wrong answer. I just want you to write this on your handout as to what you would give this, a 7, a 5, a 10. A section of colon, what you're looking at, and you see numerous a cross-section of these glands with numerous goblet cells. So I want you to rate this also. Once again, there's no right or wrong. It's however you view this slide. So what we have here is two different slides that I just showed you. And the question is, which is the more optimal stain? Well, that is a matter of preference. It's very subjective based on who the reviewer is. Many of you all have pathologists that are very preferential about how they like their H&Es. So what we have to do as scientists, preparing the slides for them, is condition ourselves or train ourselves to take a critical look at the tissues. We don't want to just look at the nuclei and see blue. Well, it's staining blue. Okay. We really want to look for crisp nuclear detail in the chromatin material, and so that gives us an example of whether this is a sharp nuclear stain or not. We also want to look at the contrasting counterstain that we see in the slide also. So this gives us a way to critique a slide rather than saying whether it's blue or pink. And the reason why I'm saying this is because the pathologist should never come back to us and have to tell us that something's going wrong with the stain. We're the scientists, and we should be able to see this before we even take the slides out to them. I am assuming that everyone does some kind of spot check, some kind of QA check with the first slides that go through. Some of you all use a control slide. But we should be able to identify if there's something going on with the stain before we take it out to the pathologist. Here that says hematoxylin and niacin combination is the most common staining technique used in histology. The diagnosis of malignancies is based largely on the procedure. And the third bullet is the key thing. Customer expectations or preferences are extremely subjective. We have been trained as histotechnologists. We know what optimal staining is, but none of that makes any difference depending on the pathologist that we're working for. So that is what we have to concern ourselves with, satisfying the person that is going to be using this slide to diagnose cases. Systematic changes that happen in tissue. Systematic changes in dye reagent integrity can present subtle or slow or progressive gross changes in the dye and reagent chemistry and performance, meaning that basically few laboratories monitor their solution and the pH or stain consistency, resulting in unmonitored progressive changes in the stain from the first slides to the last. Very few laboratories look at their slide quality midway through or at the end. We basically check it at the beginning, we run it through, and unless the pathologist complains, we really don't make any changes to that. But I want to make the point that there are subtle changes that are happening because the chemistries in those dyes and reagents are subtly and slowly changing. The results of unmonitored stain issues, loss of stain contrast between nuclear and cytoplasmic stain, weak or faded cytoplasmic stain in the eosin, nuclei becomes blurry or smudgy, basically in the hematoxylin. There is a loss of color balance between hematoxylin stain and eosin counterstain, and this is what we have to continue to look for. This causes repeated change out of the stain because there is constantly or progressively a change in the dyes or the reagents. Now I'm going to show you two slides here side by side. This is a section of, this will be a section of liver. Now you can look at the slides, and I don't know how the resolution is on your LCD players, but you can see that there's slight subtle changes in intensity from the slide on the left to the slide on the right. The slide on the left might look a little bit blurrier. It certainly doesn't look as sharp as the one on the right. The one on the right demonstrates a stronger level of eosin staining. The slide on the right was the first slide that was sent through, and then I think the slide on the left was approximately 500 slides later. The next slide pair that I'm going to show you is smooth muscle. And as you can see on the right, the staining is a little more intense with the eosin. Of course, muscle has a strong affinity for the eosin dye. And on the left, it's a little paler. Once again, first slide going through on the right and approximately 500 slides going through on the left. So what brings up these or causes these common stain issues? Generally is carryover from one staining container to another, dilution or contamination of the stain, mainly through water, diluting out or changing the pH, elevation of the pH of the dye that you're using, and a depletion of hematoxylin dye content. Why does this happen? And this is something that I want to talk about. The basic chemistry of the solutions, you have to consider the positive or negative charge within the dye. There's a charge distribution of every dye, which determines actually what in the tissue it is going to be attracted to. Solutions that have a positive charge or many cations are attracted to negatively charged molecules in the tissues. Solutions that have a negative charge are attracted to negatively charged molecules in the tissue. And so the key thing is that the pH of the solution is largely determined by the charge of the solution. The charge of the solution will determine what tissue it has an affinity for. So whatever the pH of that dye that you're using, that will actually cause a positive or negative charge to that solution, which will in turn give it an affinity for or against positive or negative charges in the tissue. We look at this next slide, and it kind of gives us a point of acidic pH or basic pH. Solutions that have a pH of less than 7 are considered acidophilic. This would be like your eosins, and oftentimes it's called eosinophilic. It has a higher concentration of hydrogen. The basic pH is pHs higher than 7. These are your basophilic stains, mainly your nuclear stains. They have a lower concentration of hydrogen. Next slide shows the subtle changes that can happen just from a slight difference in pH. Now, this is a glomerular staining of kidney, and you can see on the left the pH 4.3, which our screen here does not really show the vivid color, but if you could see that, the pH on the left, 4.3, is optimal. On the pH on the right, 5.2, is a lot fainter than the pH 4.3. And I'm showing this slide to show you that just a subtle change in pH can cause a change in stain intensity. And this will happen the more slides you run through on your staining run. The next slide is a section of colon. You can see on the left, this is a little bit better presentation. The optimal staining, 4.3. You can see very good color balance between the nuclear staining and the eosinophilic staining. You can actually see a lot of the red blood cells staining in the crypt areas. But if you look at the pH 5.2, a lot of that eosinophilic staining is washed out. You can see faint resemblance of red blood cells, but nothing like the pH 4.3. What we're looking for, some of the things that can happen, is an overstaining of hematoxylin. This is basically when you'll see a lack of nuclear detail, poor nuclear or cytoplasmic contrast, and actually you won't be able to see that much of the cytoplasmic stain because it'll be masked. If it's too light on the hematoxylin, the nuclei will not be crisp or sharp. You won't see the granular appearance in the chromatin material, and there will be poor contrast between the nuclear and cytoplasmic stains. Overstaining of ES and Y, the nuclei will lack crisp purple color because it's being masked now by the eosin staining. There'll be a poor contrast between the nuclear and cytoplasmic detail. Or if it's too light, the cytoplasmic material will be washed out. The acidophilic nuclei may not be visible. That should be like a purplish or a very slight reddish tint. And there won't be a good contrast. Next slide. A better understanding of the chemistry in the H&E stain will help the attendee with understanding how to modify or make subtle changes based on the preference of your pathologist, and basically how to problem solve staining issues when they arise. Overall coloration of the stain slide is a result of the balance of the intensity of the hematoxylin and the eosin. Now this is a key thing to remember, that the hematoxylin can stain cytoplasm, which is not actually supposed to do, and the eosin can stain nuclear basic protein. So we want to set up a system that minimizes, if not eliminates, this endogenous or nonspecific staining of elements that the dye is not targeted for. What we're looking at now is a section that should be considered the optimal stain. On my laptop, it's actually the perfect stain, seems like, but on the presentation screen, it looks a little more eosinophilic than what we would normally have. So, but what we want to look for is crisp, sharp nuclear detail, not just the blue dots. You should be able to see chromatin material within the nuclei in a granular appearance, and you want to see a very subtle contrasting balance of the eosin staining the cytoplasm and the connective tissue. So this is what premium staining systems can help achieve and maintain throughout your staining run. And why? Because it's balanced and consistent pH in the dyes and reagents throughout your staining run. Changes in pH will cause changes in the dye intensity. It enhances your QA and QC to use a staining system because you're going to have consistency from the beginning to the end. And they're developed, and this is very key, they're developed to be used as a system. Many laboratories, they'll use hematoxylin from one company, eosin from a different company based on their preference. But staining systems to really work, they have to be used as a system. The hematoxylin, the differentiation reagent, the bluing reagent, and the eosin. This is very, very critical when you have laboratories that have high volume throughput, 300 slides, 500 slides, 1,000 slides or more, because maintaining that level of staining is very important from beginning to end. So there's some basic chemistry of the hematoxylin dye. It's a natural dye from the logwood tree found in Mexico and Central America. Hematoxylin is actually a solution mixed of course, hematoxylin powder, but oxidized to hematium. It has aluminum ions, a hematium aluminum complex, and whatever solvent that is used in the dye. And this is very key. Hematoxylin has little or no staining capacity in its natural state if you just mix this up with water. It's not until it's oxidized to hematium that gives it actually the stain affinity that it has for nuclear material. Hematium bound to aluminum has an overall positive charge. Hematium aluminum binds negatively charged molecules in tissue. So this is what it's going to be attracted to. And here's the reason that it stains nuclei so strongly, because the chromatin material in the cells is strongly negative. So it has a strong affinity or attraction for the positive charge in the hematium bound, in the hematium aluminum complex. Oxidation, this is something that we see a lot, especially in your stronger hematoxins such as Harris. Oxidation of the hematoxin will happen just from light or air, and this is one reason why oftentimes if you're using something like Harris's, we keep that covered in the evening. We don't just let it continue to be exposed. Mercuric oxide or sodium iodate that's often used in making the solutions will continue to oxidize, will be used to oxidize the hematoxin. Almost all hematoxins are oxidized today by sodium iodate, but the third bullet is the most important. Oxidation continues after the formulation is complete. This is another benefit from having a staining system, because in the staining systems, the hematoxins that are there, that are used in those, are very stable. It eliminates the oxidation. When you have oxidation of your hematoxylin, this is why we have to filter from day to day. But in the hematoxins that are used in the staining system, it's very consistent, and there is no need to filter on a day-to-day basis. So that's another benefit of using the hematoxins that are in the staining system. Alum hematoxins stains nuclei various shades of purple or blue. You might even see a reddish tint to it, but it should be specific staining to the nuclear detail. You should not see a lot of non-specific staining in other areas such as cytoplasm or even mucin. Specific staining, DNA and chromatin material, non-specific background staining, sometimes in the cytoplasm, the proteoglycans, and this is where you see it most often in the goblet cells of the GI tract you'll see strong mucinous staining in this area. Many times we don't even really look at this because the pathologist, he doesn't complain about it. The nuclei stain well. But if we look very closely when we stain colon and small intestines, you'll see residual hematoxylin staining in the goblet cells. Decrease in pH results in a decrease of the stain intensity from the hematoxylin. Most commercially available hematoxylins that we see on the market are Harris, Myers, Gills 1, 2, and 3, and the proprietary formulas are basically those that are designed within these staining systems. This is a proprietary formula from the company, and as you see in the next slide, you often ask yourself, well, why is one hematoxylin different from another? What makes it different? If we look on the left at this diagram, you see Gills 3, and you can actually also put Myers and other hematoxylins such as this over in that area. You see that the chemistry from that basically is aluminum sulfate. There is basically a 3/4 content of water and a large amount of ethylene glycol. Now, this smaller volume of water and the fact that you're just using aluminum sulfate reduces, if not eliminates, the precipitation of the salts. Some of the examples that we see in that are Richard Allen hematoxylin 1, hematoxylin 2. Myers would be in that category also. If we look on the far right of this, you see Harris's. And the main difference in that is you see aluminum ammonium sulfate, a very high concentration of that. You see a much higher concentration of water. Water will cause these aluminum salts to precipitate out. And this is one of the primary reasons that you have oxidation and precipitation and why we have to filter this each and every day. This is why you see the metallic sheen on the top. But in the center, you see these hybrids, these hybrid hematoxylins. And what they are is, again, they're proprietary formulas. So to give you the exact configuration of aluminum sulfate or aluminum ammonium sulfate, that's proprietary to the company. But actually, they act as somewhere in between. They give you the benefits of both. They give you basically the strong staining, strong nuclear staining that you would of Harris's, not quite equivalent to Harris's, but very close. But they also give you the ability of your hematoxylin not to oxidize and not to have to be filtered every day, as in your Gills and your Myers. So Richard Allen 7211, the VWR premium stain, the Leica Selectex stains 560 and 560 MX are examples of those. Once again, these are hybrid hematoxylins where you don't have to filter every day. They remain consistent in their stain intensity. I mean, quite naturally, you'll eventually have to change them out. But if you're staining a high volume run, you won't get the diminishing of stain intensity in your nuclear detail. Staining systems produce well-delineated, crisp nuclear staining. The convenience of a Gills type hematoxylin is no precipitation, no filtering. These staining systems of hematoxylin give you a high throughput and capacity and a stable pH. This next set of slides that I'm showing you, and my laptop shows one thing, but the projector shows something different, so I don't really know what you all are seeing in the audience. But the slide on the left is a section of colon that was stained. And if you can see very closely, I don't know if you all could see my pointer, you could see the goblet cells here. You can see a slight tint of hematoxylin dye in the goblet cells. And what happens is the goblet cells produces mucin and spills it into the cavity of the colon or the GI tract. And this acts somewhat as a lubricant so that food or waste can pass through. So that is why you see this predominance of mucinous material here within the tract of the colon. Now, we do this stain for a pathologist. Actually, he could care less about all of this endogenous, non-specific hematoxylin staining. This is actually just junk. If we look at the slide on the right, what you'll see is the goblet cells are basically clear of any mucin. And this slide on the right was actually overstained, stained longer than the slide on the left. And I did this to make a point that even though I stained longer in the hematoxylin, because I used the staining system and the differentiation solution in the staining system, I was able to clear out a lot of this non-specific staining. You can see it's a lot lighter now than before. You don't see the staining of the mucin in the goblet cells here. Shows the same thing. On the left, you can see the goblet cells in the glandular areas. You can see the intense hematoxylin residue that's being picked up by the mucin. You can see on the right, I overstained this slide once again, so you can see it's darker staining, but there is an absence of all that non-specific mucinous material. Once again, what we're looking for is balance of coloration. So this is what we're looking for. If you look at the slide on the left, you see good nuclear detail in the nuclei. You can also see a balanced eosin stain. You can see on the capsule of this, the eosin picking up in the connective tissue. You can see on the right an even sharper nuclear stain, not just a blue dot, but you can see the chromatin material, you can see the nucleolus within the nucleus. And this is what we want to try to achieve. And I'm waiting for that to pop up, but even in that slide, you can see even with the strong presence of the B and T cells on the slide on the left, you see very strong nuclear detail, which is what we would expect in a lymph node because it's so rich in DNA material. Okay, here you can see a predominance of T and B cells in this lymph node, which actually gives us a very strong nuclear stain. And when we're looking at lymph node, sometimes it's so dramatically blue because of all the nuclear detail. But you should also be able to see a slight blush of the counter stain of the eosin, which is what we have here, balance of coloration. Here on the slide on the right, the same thing. You see good sharp nuclear detail, but you still see the background, the slight subtle blush from the eosinophilic staining. So the next slide, which has just popped up, is basically progressive and regressive staining, which in your laboratories you're doing one of these. Regressive staining is basically where we stain, we overstain with a hematoxin that basically stains everything, and this is primarily Harris's hematoxin, pretty much the strongest hematoxin on the market. Then we regress. We go in and we remove that hematoxin from everything except the DNA material. And then we continue staining with our bluing method and then with our counter-staining eosin. In progressive staining, which is basically Myers, Gills 1 and 2, and often Gills 3, we stain, we rinse, we don't regress, and then we continue staining. These are weaker hematoxins, and there is no need to actually regress through the use of an acid alcohol solution to differentiate. So basically you stain, you rinse, and then you continue staining. Now, the staining systems come somewhere down here as a third, where you stain, you rinse, and then you use a mild acidic solution, not something strong like hydrochloric acid for differentiation, but you use a mild acidic solution, and it's not even considered differentiation. But you do that just to clean up the nonspecific or endogenous areas of hematoxylin, such as the goblet cells, the excess mucin, or any endogenous nuclear or hematoxin staining that you see in the cytoplasm. Once again, this is what we're trying to achieve. What you should be able to see here is very sharp, crisp nuclear detail. You should be able to see the chromatin or granular structured material within the nuclei. You should be able to see the contrasting counterstain in the connective tissue and the slight blush of eosinophilic staining throughout. Now when we monitor our slides in the morning, this is what we should be seeing. And sometimes I have a concern about using a slide that has so much richness in nuclear staining that we don't really see a balance, such as using a lymph node. Some labs do that, and I certainly couldn't speak against that. I have a concern about that because there's so much nuclear staining in that it kind of masks out sometimes your eosinophilic staining. So I often recommend that you use a tissue source that has a lot more balance of nuclear and cytoplasmic material. So background staining is reduced with the chemistries of a differentiation. When we differentiate after we stain, even after hematoxylin, Harris's hematoxylin, we need to regress or pull that back out. Differentiation decreases the ability of the hematoxylin to bind to other tissue sites, and it actually pulls it out. What's typically used is an acetic acid solution, 70% ethanol, well, the acid in 70% acetal, or 70 in water, or 70% ethanol, or an HCl dilute solution in alcohol. Common progressive hematoxylins, as I said before, Myers, Gills 1, 2, and 3. You see a question mark behind 3 because oftentimes Gills is used in a regressive fashion because it's pretty strong, and it can be used with a differentiator, a hydrochloric acid differentiator, to pull some of that hematoxylin back out. There are many labs that just use the Gills in a common progressive manner, but there's other labs that use this in a regressive. Now, Myers oftentimes is much too weak for some staining, for some histology staining. Gills 1 is often considered too weak for histology tissue staining. These can be used oftentimes when you're using immunohistochemistry, but if you're increasing your staining time by using something like Myers or Gills 1, like 5 minutes, 10 minutes, or something like that, you might want to consider trying the Gills 2, because you could probably achieve the same amount of staining in 2 minutes with Gills 2 as what you're achieving in the Myers. And that's just a food for thought. So common regressive stains, the most common one, or the only one that I really know about, the true regressive stain is Harris's. It is so strong that it overstains everything. Now with some hematoxins, the tissues is not purposely overly stained, but light differentiation is still used to optimize the staining contrast. And this is what I'm talking about when I talk about the staining systems. You don't overstain, use a lighter or weaker hematoxin, but you still use some kind of light or mild acidic rinse to optimize or differentiate the tissue. Light differentiation solutions used with progressive stains or weakly acidic. This is not like the HCl that you would normally use. It's a mild acidic rinse almost. Acetic acid in aqueous or alcoholic solutions. The solution is buffered, and once again, this is used with the weaker hematoxins that you would use. Start with the second bullet, differentiation solutions used with regressive stains, usually 70% alcohol and 0.5 or 1% HCl, and this is very key. Alcohol, because sometimes people just use water with their HCl, but alcohol softens the differentiation process and makes it a lot controllable, because just an aqueous HCl solution is a lot more aggressive. So you will rapidly pull the nuclear material out, and sometimes too rapidly, so that it will start to come out of your nuclear material also. So it's more advisable to use HCl with an alcoholic, 70% alcohol. Why would you differentiate a stain that was done with a progressive stain? Well, once again, to remove the non-specific mucin staining, remove background staining, and actually to increase the crispness of the stain. You'll oftentimes see with your hematoxylin a slight hematoxylin tint on the slide, and this mild differentiation can be used to actually just clean that up and make the slide look a lot brighter and crisper. An example again of the colon, which is what I showed you before. I'm going to skip ahead to the next slide, which is another example, and I'm going to stop for a minute and show you. See once again these rivers of mucin. You can even see the mucin here in the goblet cells. For your pathologist, he may not complain about this because he's not really looking for that, but this is all garbage. This is all junk. And if we as scientists can clean this up and give them a better quality stain, then we should consider doing that. If you look at the slide on the right, once again, I overstained this as opposed to this, just to make a point, to show that even with overstaining of the hematoxylin, we were able to clean out all of this non-specific staining here. Of course, this stain is too dark for probably what you would present to the pathologist, but we've taken out a lot of this endogenous hematoxylin staining material that the pathologist could care less about, and we've cleaned up the slide. Here is another example, and I'm not going to belabor this. I'm going to just switch to the next slide. If you can see on the slide on the left, okay, on the slide on the left, all of this mucinous material, all in here, is so dark it's almost the color of the tissues. But here we've cleaned most of that out. And once again, this slide was overstained. But we've cleaned a lot of that out. We've given a sharper picture to the pathologist. So can you imagine doing this on your normal staining run and using this kind of staining system with doing your optimal hematoxylin stain time, but you clean up all of this endogenous material? And that's what we want to try to consider rather than just doing a stain and giving them the doctor the stain. We want to optimize the stain. Buffered reagents in the staining systems, the solutions are buffered. They're designed to maintain the specific pH, increases the clarity and the definition of cytoplasm, removes background staining, and contains no alcohol. Let's talk about bluing. After we've differentiated, we need to put the tissues in an alkaline solution to actually blue them up from the hematoxylin dye. So bluing is necessary to convert nuclear coloration from reddish purple to a crisp bluish purple. This is key that the pH of these reagents is between 7.5 and 9.0. Now we've already discussed about optimal pH being somewhere around 4.5 or something like that. But here we're putting this into the bluing reagent that is extremely alkaline and has a much higher pH. Some examples of that we see here are tap water. Typically, wherever you are in the country can be different, but tap water has close to a pH of 8 in general. Scott's tap water is usually very stable. Ammonia water it sometimes can be too harsh. Lithium carbonate is a good bluing agent to use, but sometimes it can fluctuate in the bluing intensity. And buffered solutions. So basically, buffered solutions or Scott's tap water would be about your most ideal way to blue up your tissues. So how does bluing work? Fewer hydrogen ions in solution affect the structure of the hematoxylin. There's a loss of hydrogen. Bluing agents enhance the contrast of the H&E stain by increasing the crispness of the hematoxylin stain. Changes it, as I said before, from purplish to purplish blue. Many pathologists like to see a reddish tint to their hematoxylin. Bluing agents enhance the contrast of the H&E. Hematoxylin coloration is changed from purplish to bluish purple. And once again, the pH is somewhere between 7.5 or 8 to 10. Now this is very key because when we start talking about changes in reagents, we have to look at this bluing reagent is the last major solution that your slides go into prior to going into eosin. If you have an optimal staining pH for eosin is about 4.3. If you have slight and residual carryover from your bluing reagent, whereas you don't have a good enough rinse, progressively this slight and residual carryover will change the pH of your eosin, which means the intensity of your eosin will progressively change the more slides you run through. Some bluing reagents to consider: tap water. The pH may be too unpredictable. You'd be surprised at the different pHs as you go across the country. Some areas, some regions have very high alkalinity, some have very low. Ammonia water, the pH may be too high and it could be too harsh on the tissue, so it's not the optimally desired bluing reagent. Scott's tap water or buffered solutions are more effective and gentler on the tissues. Buffered solutions designed to maintain that pH in 8.0 to 8.2. This is another reason for using a staining system, because that pH will remain the same. It produces the same intensity in the chromatin material. It's gentler on the sections, and it's excellent with frozen sections and may be used with any hematoxylin. So while it's designed to be used within a staining system, you can actually use some of these buffered differentiation reagents with any other hematoxylin. I think Clarifier is one that is used by Richard Allen. Define is another one that is used by Leica Selectech. The blue buffer, I think, is what it's called with Leica. So I'm going to really run through these slides about eosin, just general information about eosin. It is an acidic dye. It has a negative charge. It binds to positively charged proteins in the cytoplasm and connective tissue. And this is why the cytoplasm and connective tissue have such a strong affinity for the eosin. It's very acidic, negatively charged at a pH of 3.5 or higher. The stain intensity is highly dependent on the pH of the solution. pH above 5 in your eosin, and the stain intensity begins to drop off. Now remember, we just spoke about the buffers. The bluing solution being highly alkalinic, have a high degree, high pH. So if you're progressively carrying some of that over residually, even though it's not that much, by the time you hit 500 or so slides, you're adjusting this pH of your eosin. pH below the intensity, the stain becomes murky. Commercially available eosins, alcoholic eosin, aqueous eosin, eosin with floxine, they may differ with respect to the eosin concentration the solvents used. Now, many times past, you'll see in your staining runs that there was always an alcohol placed in front of your eosin. And that actually originated back when we were using aqueous eosins, because what that did was it helped remove the water from your slides or from your tissues before we're going to the eosin. Eosin in the presence of water will differentiate back out. So many of you know that once we stain in the eosin, if we rinse that too long directly in water, it's going to pull that eosin right back out of the tissues. So in procedures in the past, we would go into an alcohol before we would go into the eosin, and then we would come out of the eosin and progressively go back to our alcohols. In many of the eosins today, the eosins have a much stronger content of alcohol, which gives it a much stronger affinity for the tissues. So in a number of the products that you have out today, I think Sigma is one company, Richard Allen is another company, Leica is another company. They have a higher content of alcohol in the eosins. So in this respect, you could very well eliminate that alcohol that you go into before you go into the eosin. And the slide that I showed you in the beginning that showed the really red blood cell staining, and I said it looked like floxine, that was stained with a method where I did not go into alcohol first. I used a very strong alcoholic eosin and went right into that and still got the same staining intensity as I would with floxine. So just a matter of thought, some of these eosins on the market can allow you to eliminate that alcohol that you go into before you go into your eosin dye. So pH is critical, especially with the eosin, to determining the charge of both the dye and the tissues. As the pH of the dye goes up, the charge on the comes down, the pH of the charge goes up. And conversely, as the pH of the dye goes up, the charge on the tissues goes down. So this is why it's very important to maintain the pH in your staining solution from beginning to end. So reduce eosin staining intensity or decrease staining capacity is often a result of the changes in the pH. Carryover of alkaline tap water, as I mentioned, inadequate rinsing to remove the bluing reagent, and contamination with bluing reagents. As the pH is reduced below 3 to 4, the net positive charge of protein increases, acidic groups of eosin becomes neutral, eosin binds non-specifically, and there's a decrease in the staining that becomes murky. So once again, to look at the slide that I showed you in the beginning, just use this as a quick example. Again, I'm not going to stay on this slide. You can see again the drop-off in the stain intensity from the eosin from pH 4.3 to 5.2. Differentiation in a solution containing water has to be monitored. Most differentiation solutions are 80 to 95% ethanol. If the water is used to remove the prior clearing reagent, it will also leach the eosin following through the cover slipping. The addition of water to alcoholic eosin, as I mentioned before, can cause precipitation. When using the alcoholic eosin, an alcohol rinse should be placed prior to the eosin solution, but with using some of the alcoholic eosins that are on the market now, you can eliminate this step. Once again, balance of coloration. We've seen this. You can see the nuclear detail, very clear and very crisp, very sharp. So when we look at our slides, this is what we want to look for, not just to see if we see blue staining. We want to look very critically inside the nucleus. And the last thing that I want to speak about now is, as soon as my slide transitions, is optimizing the H&E stain by using the system. Benefits are it reduces nonspecific staining, it sharpens the nuclear detail, optimizes the counter stain, and optimizes the pathologist for the pathologist's preference. And the key thing is it enhances the QA on consistency and reproducibility. Here you see normal staining, elevated pH, no differentiation. You see a lot of nuclear staining here, and then Gill's hemotoxin. And I present this to show, depending on what your pathologist likes, you can manipulate these stains to give you whatever intensity that you want. But the key thing is maintaining that consistency. You might say, well, this is too dark, and there's not enough contrast. But if that's what your pathologist prefers, then that's what we need to do, and that's what we need to maintain, whether we're doing 1 slide or 500 slides. So the next slide is another shot of multiple stains. You can see the different intensity again. We're going to be wrapping up now, but this is what I wanted to mention about how we go about optimizing the stains. This is a chart that I use when I'm matching or trying to improve on a stain. So whatever your protocol is, you would put that here. And as you see, before going into the eosin step, I do not have an alcohol step, which is by preference. You can continue to put your alcohol step there, but the stain intensity that I'm showing you now in these slides, I did not use an alcohol before the eosin. So you can achieve optimal staining without that. And I'm not saying that you should go and change your procedures. I'm saying that you have options. So you start off with your basic staining run. This is your standard protocol, and you plug in the numbers for whatever you do, however your lab is set up. But then you set up this table, and you go by, and the only variables that you really need to consider are the hemotoxin, the differentiation, the eosin, and then the 95% alcohol after the eosin. Because basically, when you want to start optimizing your stain, these are the four different things that you're going to adjust. If it's not dark enough nuclear staining, your next staining run, you want to actually run maybe 4.5 minutes. Your eosin, if it's not bright enough, you want to run maybe 45 minutes. And you can manipulate the stain too with this 95% alcohol, because the longer that you leave it in the 95% alcohol, remember, even with this just residual 5% water, that is going to progressively start to slowly pull the eosin back out. So if you start manipulating this or changing this, you don't always have to go weaker on the eosin to get a lighter stain. You can actually leave it in this step maybe 30 seconds longer. So once again, you have options. You can either change the timing on this or change the timing on this, or both. The key thing is to set up some kind of system like we have here, where you can optimize, or progressively optimize the stain to your pathologist's preference, and then you lock that in to whatever the preference is. Now, I can email this chart, or you can probably get it from Sakura, just to use as a template to make your own. And the handout is basically too small to read. So the next slide, and these are going to take a while coming through because they're all images, so I'm going to rapidly race through them as they come through. Once again, the slides that I'm about to show you now, or that should be popping up, are optimal staining, or what would be considered as optimal staining. You can see the very sharp, crisp nuclear detail in these slides. So you see the nucleolus within the nucleus. The next slide is one that we previously showed, so as soon as it pops up, I'm going to switch to another. But it also shows balance of coloration. Once again, on this slide, you see all the mucin deposits. See that over here. So we're wrapping up now. These staining systems are most beneficial for high volume throughput stainers. And I'm just listing 2 examples here. I'm certainly not promoting either one. I'm just saying these are high-end, high-throughput stainers. The first one that I'm showing here is the Leica ST5020 stainer. You will note that it has 3 different rows for staining. You can set this up however you want. You see that the containers carry roughly about 250, 400 to 400 mils of reagent, but it does have a high volume throughput capacity by having 3 rows there. The user has the ability to program a number of different protocols. The rinse stations are here, but note the size of these containers. That's what I want to draw your attention to. So the next stainer is the Sakura Prisma stainer. You see that it has kind of a slightly larger footprint. This is actually the staining portion here, and this is the slide carrier where they go over to be cover slipped. But I'm more concerned with this area here. So I'll show you that again on the next slide. Now, to be considered on this, once again, this is the area here. And you can't really see the containers, but on this next slide, you should be able to see that. Now, this is another high volume throughput stainer. The containers are much larger than the ones on the previous stainer that I showed you, which means that you have a lot more reagent that you can put in these. This will give you an even higher volume throughput, but once again, you need to consider how often you need to make changes. So one key thing about this stainer, as opposed to the other stainer, is the rinse steps. Now, the rinse in this stainer here has a very, very good flush going through, as opposed to the other stainer, which has kind of a trickle of water. Now, what does that mean? That means if you only have a trickle of water on your rinse steps, then that means that you probably have to rinse longer to make sure that the reagent or the dye that you were using has been rinsed out, such as hematoxylin. If you have a much greater flush or flow of water, such as this, then you can actually shorten your rinse cycles, maybe down to just a minute, and still have optimal rinsing. Rinsing is very important, as I said before, so that you don't have carryover of reagents. Carryover of reagents is going to change the pH of your solution. So we want to minimize any carryover, and certainly rinse steps are very important. Now, the last point that I want to make is that there's been some discussion in the industry over these kind of stainers, whether it's this stainer or the other stainer, and the prevalence of floaters in these systems. Well, most times a floater on your slide will come from either the grossing step or the embedding step. Very seldom do we ever see floaters attaching to tissues in a staining cycle, because primarily they get rinsed out. You very seldom see tissue lodging itself, or a floater lodging itself onto a tissue. I'm not saying that that has never happened, but that incident is very rare. So I really wanted to just touch on the point that I really don't agree with the fact that these type of stainers, these dunk stainers, dip and dunk stainers, are not really good and promote floaters. If you're having a problem with floaters, it's probably 90% of the time coming from some other area other than staining. If you think it might be coming from your staining area, then increase the rinse rate that you have on your stainers. So I just wanted to kind of dispel that myth about these type of stainers not being that good for staining because they promote floaters. So this was basically the last slide that I wanted to show, with the exception of one more ending slide, which is considered an optimal stain. And this is what I would consider optimal, but you might say it's too light, too dark. I would challenge everyone in the audience now to go back, since we've talked about how to take a critical look at your stain. Go back to those that you graded in the beginning, and you can do this on your own, and see if you would give it the same grade that you gave it before. Note, we really need to look critically at the nuclear detail. We really need to look critically at the contrasting cytoplasm and see what kind of grade we would give that. So this slide that I have here is what we would consider an optimal stain. Once again, it's all subjective based on the preference of your pathologist. So, last slide I want to show is I just want to say on behalf of Sakura Finetech, thank you for attending. I hope that you received something out of this session that can help you in monitoring your H&E stains and actually troubleshooting when you have issues with the staining. The staining systems, there's a number of companies out there that have these. If you're doing high volume staining in your laboratories, I would certainly encourage you to contact those companies, and they will send you samples, and try to use those on the high volume stainers that you have. Thank you very much for attending, and I'm going to turn the session back over to Alicia.
Just a couple of things. If you haven't registered for next month's webinar, please do so. Registration is open on our website. Also, our featured product, Skip talked about this at the end of the presentation, and it is our automated site stainer. It has a very through capacity up to 500 slides an hour. You can run H&Es and special stains on this. It is compatible with all histology, cytology, and patent non-gin protocols. And like Skip had mentioned, you can link it to your cover slipper, so it becomes a truly walk-away instrument. Until next month, have a great day.